Thank you very much. Today our talk will be about infective endocarditis in echocardiography. It will be a guideline comparison between 2015 and 2023. I brought here the picture of William Osler. He's the godfather of infective endocarditis, and he was the first to address the infective endocarditis. And this is his library. Objectives: we will summarize key updates, compare similarities and differences, discuss advanced imaging rules, and apply American Society of Echo and ASC diagnostic algorithm, highlight emerging updates and future directions in imaging. These are my sources. All are the guidelines. So the infective endocarditis matters because of the high mortality, 15 to 30%. And actually 30 to 50% of the patients will need to undergo surgery. Echo remains the cornerstone of the diagnosis, and the increasing in device-related infective endocarditis cases, as we know nowadays, is very common to see a patient with a device or a clip or a valve. So we will next see a short video about how difficult it is sometimes to diagnose infective endocarditis. Then we will have like some questions, not about the video. They are just general questions, and I would like to give you like 30 seconds for the sake of time. A patient has a staph aureus bacteremia, but negative transthoracic and no clinical signs of infective endocarditis according to modified Duke criteria. What is the likelihood for the diagnosis of infective endocarditis would be missed if transesophageal is not performed? You can share in the chat, or you can share here, guys. 50. Actually, it is 15%. So the next slide will be another question. What is the negative predictive value of multiple TEE to roll out infective endocarditis? Multiplan. Let's give me a number. Guess. It's more than 85%. After complete resolution of vegetation, what is the proportion of affected valve retain normal structure and function? So it's 10%. That's how much is infective endocarditis is very bad. So the updates of the summary of the updates of the last guidelines. Immediate TE for all the suspected IE patients, urgent TE if the prosthetic or cardiac implantable electronic device, poor TE window or high clinical suspicion, short interval for repeating echo, strong integration of multimodality imaging, and 3D TE emphasized for complex anatomy. Structured echo reporting becomes a standard. We will discuss most of these points in some details. Number 6 is heart team multidisciplinary care is highlighted. Imaging drives timely surgical referral. The comparison of the similarities between all the guidelines, they all agreed that transthoracic fluorescent in TE if non-diagnostic or high suspicion, repeat imaging if suspicion persists or new clinical changes. 3D-TE preferred for surgical and prosthetic evaluation, now all universally adopted. Intraoperative TEE is mandatory during valve surgery, and multidisciplinary heart team management is essential. These are the differences between all of them. So the ESC mentioned that the multimodality imaging, the only guideline that fully integrate the PET-CT into diagnostic criteria. ASC, both of them and ESC have structured report, but they are different. That ASC provide detailed template and ESC mandates structured data. Timing for repeating echo, ASC was more aggressive actually, 5 to 7 days, and American Heart Association 7 to 10 days. And if there is a cardiac device and we suspect infection, the ESC explicit PET-CT and integration into for device infection. Team-based, ESC makes heart team mandatory, not just encouraging it. For structure reporting standards, the ASC is a template centric, which gives the Echo Lab exact structure, what a report should contain, with defined sections and core variables. For the ESC, it's on a structured data-driven imaging report that integrate into overall diagnostic and treatment pathway for infective endocarditis, even though it doesn't provide a universal reporting template. Both of them mandate emphasizing the structured and reproducible report. Using the standard view and measurement should include the vegetation size, mobility, leaflet involvement, degree of regurgitation, prosthetic sewing and ring, periannular extension, abscess and fistula, interventional and structural implications. Another question. So we still have only 2 questions. Sorry for boring you with these, but I will just, it's just a brainstorming. So in a patient with native valve endocarditis, what is the size of the smallest left-sided vegetation that can be detected by 2D-TE? It's fine. I hear answers, some right answers. Let's see the chat. Yeah, actually it is C. What is, in a patient with a native valve endocarditis, what is the size of the smallest left-sided vegetation that can be detected by transesophageal? Some of you got it right. So it is 1 millimeter. So this is like an algorithm that I brought that all the guidelines agreed in both infective endocarditis and a native and prosthetic valve. First of all, if suspected infective endocarditis, immediate transthoracic bedside should be within 24 hours. If transthoracic is positive, vegetation or abscess found, initiate management and perform TEE for detailed assessment, especially a prosthetic valve or cardiac device. If the transthoracic is negative, clinical suspicion is still high, urgent transesophageal, ideally within 24 to 48 hours. There are special situations. If the patient have prosthetic valve or cardiac device, then it's preferred to go for PET scan if echo is inconclusive. Persistent suspicion, we will repeat transthoracic and transesophageal in 5 to 10 days. We followed the guidelines for higher sensitivity, not to miss the patients. Surgical planning, we need to utilize the 3D-TE. Advanced imaging role, PET and CT detect prosthetic valve infection and cardiac device. CT angiography identify abscess especially in prosthetic valve endocarditis, if we find difficulties in viewing with echo. 3DT defines vegetation, anatomy, and surgical planning. Strain detects subtle LV dysfunction, and that is sometimes underutilized in many places. The new emerging diagnostic aid is AI Echo. I brought the latest study that was published in October 2025. It was titled as Automatic Detection of Vegetation with Transesophageal Echo and Infective Endocarditis using Artificial Intelligence. So they brought 329 patients, and it was a retrospective observational study. An AI-based model was trained on vegetation detection. They found out actually the vegetation detection at the frame level achieved promising performance of positive predictive value of 0.83 and true positive rate of 0.75. Actually, it's very nice finding, but it can facilitate and accelerate infective endocarditis diagnosis by non-cardiologists. Diagnostic challenges: prosthetic valve shadowing, and that is very common in echo. Culture negative infective endocarditis, and I guess that's the most patient were missed or delayed diagnosed. Device related infection, and it's recommended that we follow the PET-CT for diagnosis if we suspect. Early abscess formation that is rarely detectable. Over-reliance on single modality, so we should apply multi-modality imaging or repeating of echo. Future directions and key takeaway: multi-modality imaging and AI integration is the future. Early PET-CT improve the outcome. Repeat echo will remain vital. Endocarditis heart team concept should be implicated in every center treating patients with infective endocarditis. These are my references. Thank you very much. If you have any questions, you are welcome anytime.